double med. Is what came out of this subset analysis from a study called Reprieve, which was first, how come I'm not moving? It was first presented in Munich last July. We've already talked about it, but we're going to talk about it more. So we're going to talk about two specific studies related to cardiovascular disease, which is just cardio, heart, vascular, the blood vessels, the heart and the blood vessels. And what's new? The new guidelines about men and women, just HIV, people living HIV positive is what it says, not men, women, transgender, that statins should be recommended. But first you have to have the conversation with your doctor, and they have to recognize that the number one cause of death in the United States is heart attack and stroke. And then if somebody has diabetes, you go like times 2 or 10. And then if HIV, you go another times 2 or 10. Because HIV is just, and people have probably talked to their diabetes doctor about how important a statin is for diabetes. This is the same conversation, and this is like why we're here.
And if you
It's so that you guys can become informed and then go live longer and go talk to your doctor about, you know, this time, can we just talk about heart disease and prevention? Sorry, John. I'm sorry.
No, I was just gonna say that, and then you add drugs like crystal meth. That's like 4 times.
Times 2 times 10, right?
Yeah.
And then, thanks. Also, there's this, you know, why do women have more heart attacks and so why does HIV flip that upside down?
Yeah.
You know, it's paradoxical, right? It's mysterious. So they gave it a name, immune plaque paradox hypothesis, because there's some evidence that women have more inflammation than men when they go into menopause. People get like inflamed. It's this, they don't know, you know, but they're trying to explain why women have higher risk of heart attacks and strokes. And we just know less about women. We know less about women in terms of lipids. We know less about women in terms of the symptoms they have when they have a heart attack or stroke. And maybe women have more microvascular dysfunction, meaning the small vessels in a woman get affected like a diabetic versus the large vessels don't get as affected. So when you do a coronary angiogram, you don't see blockage in the big vessels, but they still have a heart attack because of this other effect downstream with the little tributaries. So, you know, this is hi to whoever's on, Victor. That
You have to remember.
Oh, that's the plumbing. That's just what we look like. You know, maybe that's the value of the picture. That's all I meant. Thanks for slowing me down a little bit.
You're going to see the screen? Okay.
So that's just what I said, you know.
That's great.
We've known for a long time. We go, oh, women, and in fact, the formula to calculate the best that we can do without tests, just talking without like a picture, just blood tests and talking to people, is we use blood pressure, gender, man or woman, and if it's a man, it's worse. The calculation goes up. If it's a heart attack or stroke in the next 10 years, goes up. We use this calculation, diabetes or not, smoking or not, hypertension, age, oh, right, and cholesterol and LDL, right? That's a lot, right? But it doesn't account for family history, doesn't account for HIV. So we're already underestimating for the men or the women, and we're really underestimating for the women with HIV. This is a study in 2007 that showed twofold higher risk of heart attack or stroke in women with HIV. That's basically it. And this should be posted soon. The Reprieve study we've talked about, but basically there was a 35% decrease in heart attack or stroke, and a lot of them die, right? And still you're lame for life, or something bad happens to your heart, you can't function. And they use pitavastatin that Wanda asked, oh, I should ask for that. It's not available in the US, and it's a statin. And so we all know that they're all going to be about the same. It's what's safe. It's what's more important. And this is the second study I'm talking about. The first one I kind of just said it showed an increase years ago in 2007, but then women just haven't been studied. So in the reprieve, what it found is women from rich countries were even more at risk. And it had to do with they weighed more and they had more hypertension and maybe some other stuff if they look at the subset analysis, but they didn't smoke more and they didn't have more diabetes, they said. So hopefully I offered a few things, for women. We have to remember the women in the room. And at the Scripps Symposium in February, it's a pretty famous symposium. It's going to be on cardiovascular disease in women. And there's nothing about HIV. There's pregnancy and hormones, menopause, cancer, and heart disease, but not HIV. So reprieve, just so you know what it is, it was a randomized trial. It's closed, and UCSD was a site. Randomized means they send one group that way, one group that way. So it takes care of like selectively picking people for the study to make sure it looks really good or something to prevent, vascular events. So vasculature, the blood is just blood vessels. Stroke, vascular event to the head or vascular event to the heart.
For those that don't know what a statin is, could you tell them?
A statin is the most common drug used to lower cholesterol and lower the LDL. There's not really a drug that'll make the HDL go up. Exercise does that, very well known. So that's why they have the next, program really to just offer that. Yeah. And there's a new class of drugs called Repatha and Prelude. Where's the pharmacist, right? Yeah. Anyway, that if you can't tolerate a statin, ask for an injectable cholesterol medicine. Super expensive, but it'll save your life if you can't tolerate the statins, because that's the big fear of the statins. Yeah.
Wow.
Oh, I know. That I took from another slide. I should have put female gender, but yeah, not having sex with women. That'd be the greatest. I don't know. Like, I don't think anybody I know in this room qualifies for that group.
Well, nobody.
Everybody in this room goes with men, huh?
I was just wondering, is that why I'm really healthy?
No, thank you for pointing that out. Right. It hasn't been posted to the site yet, so I'm gonna change that. What should I say? Female gender? Cis female? It's definitely accepted. I'll just put cis female. That's on the IAS website for the International AIDS Conference meeting. So this is what your doctor, actually it's recommended for all primary care, family practice, internal medicine, primary care own clinic, that they use the American College of Cardiologists it's a calculator that guesses what a person's risk of a heart attack or stroke is going to be in the next 10 years. And if you score like if 7.5 out of 100 might have a heart attack or stroke, the cardiologists say, let's give all 100 the met to save those 8.
Right.
That's how their guidelines go, right? And then you have to be specific and talk to your doctor. But this is, what I said. TC is total cholesterol, the HDL, the sex, the gender. I should change that. Yeah. Okay, yeah, questions.
Okay, because this study is so old, were they actually checking women first their HIV status, whether they have an AIDS diagnosis or just positive or things like that? Because my understanding is that the earlier you're detected, the more your test results come as if you were actually had never gotten it. You test early enough and you're suppressed. Whereas if you have older and gotten sicker, then you are at risk. And this is everybody, it's not just women, but everybody.
Yeah.
Basically, you're at a higher risk group.
Yes.
And because women were actually, especially then, were underdiagnosed, undertreated, things like that, that may actually also fall into that. There's a lot of variables.
You are an amazing advocate for women. Thank you. No, thank you very much. But you're right. That one study which showed it so far back, right? I mean, the positive part I was trying to say was that we've known for a long time, they just haven't done studies in women. But finally in 2024 was what I was talking about. That's a brand new study, I'd say, from Munich. They finally had like 35% of the cohort was women, which is pretty good. But if you think on a global populations, we should have having like 52% of everything. Right? So, but it was still enough data to get good results. So that part's really positive. And that I'm just going to end on one thing, hopeful, and then pass it to John. Just thank you for listening. If you have questions, Dr. Torres can probably answer them. It's just kind of like a shout out to Jill Biden that I didn't know what an advocate she was specifically on recruiting women into research, medical research. So, now I can't breathe. You know, we all have to keep our ears open. And there's this great email from Christy's place about just keep listening. And there's going to be so much to respond to. Just pick 3 things.
And I bet you stay involved, Joe Biden.
Yeah, she will. Yeah. All right. Today's about heart attack, stroke prevention. And I hope some people share their stories, you know. John's giving me permission to talk about anything, but he's got a sense in his heart.
No, I'm just
Every
giving
part
you
of his
all,
body.
just wanted to give you all a little teaser because, how many, if anybody in here has diabetes? Okay, well, as you know, or those of you that don't know, how many, about 5% of the people that took protease inhibitors, which is a class of drugs that truly turned the tide, you know, that class of drugs saved all the population that's HIV positive from then on. However, 5% of that, 3 to 5% of those taking protease inhibitors suddenly develop hepatitis. And so this
And diabetes.
right.
Right.
I mean, I'm sorry. That's right.
Yeah, you're right. Yeah.
And so just call my rap name is 3%. 50 cent, 3%. Okay. So I wanted to just show you a little bit more about what it is to get diabetes, because just because you don't have it today, you can easily have it tomorrow, especially if you're not exercising and if you're not keeping yourself healthy, your chances for getting diabetes goes up and up and up. And because I was pre-diabetic for many years, so I basically was a diabetic in denial, you know, really, because and because I'm thin, I look in the mirror and go, I guess not. I'm not getting any fatter or anything. So why am I getting diabetes? And that's what they told me. But had I listened to the doctors to begin with, which is why it's great that you're here, because it's never too late to get on a healthy diet. Okay. And really a heart healthy diet, you know, the Mediterranean diet, which is great. That's great. That's probably one of the best diets there is. And that's a preview for you. But I just wanted to tell you quickly that in March, we will speak more heavily about diabetes, okay? More in depth. But I wanted to show you what kind of crap I have to go through every day. You know, you'll start you off probably with just insulin shots because you're basically just protecting yourself, you know. And then, you know, it gets really old, or if you're not being compliant, they may put you on this, which is called an insulin pen. Okay, and it's not hard to use. And actually, I don't know why they don't start. Well, I can tell you why they don't start from this, because it's more expensive. And money talks. If you don't have somebody advocating for you, you get none of this. Okay. You get the little insulin injection, and that's it. And yet with this, you just put it on like that. You dial up your how much insulin you need according to a graph that your doctor will tell you. Okay, and if your sugars are higher and go higher and higher, you have to give yourself a little bit more and a little bit more. Now, as usual, I've lost my phone. Oh, anybody see a phone around here? Anyway, if you, oh, it's right here. If you are blessed enough to get some of this technology, it comes like this. And you've probably seen it on TV now. They're starting to advertise a lot more. But this little puppy is a launcher, you know? Think of it as the rockets that are being sent off, but hopefully yours doesn't crash. Blow up. But you press the button here and you can put it on the top of your butt area or on your arms. And it looks. Anybody mind if I take off my shirt? Right. Music, please, music. Okay. Where I like to put it usually is just on the back of my arm. It's right here. Okay. Now, the reason why I wanted you to see how it works when you take it off is because the bitch. Okay. I mean, it's not that hard. For me, I'm so used to pain that it doesn't do it. But it is, if you end up putting it here, which you can, and your male, it's just like you're ripping everything off. So, although you can shave, you know, but you literally just have to use a little brute force and get it off. And this is what it looks like. It's just a circle, and it does have a tiny little needle there. Now, there's some people that are squeamish about needles. It really doesn't hurt. For the most part, no big deal. Now,
Is it administered over time through that needle?
yes, this lasts 10 days to 2 weeks. Okay, and you have to change it. And then what happens is you look in here in your phone. If you don't want to put it on your phone, they have one of these little controls. Okay, it looks just like a phone. Oh, one's already disappeared. Anybody have one of them?
Yeah,
I don't know. I can read it. But this is what it looks like. You know, you can turn it on and it'll give you. It'll show you Dexcom 7 that my sugar's at 328.
Wow.
That is not good. But I did take my medicine. I didn't take my medicine today
Oh.
for the purposes of science.
Oh.
I hear myself besides. It's so So with 325, basically you start going up one for every 50 roughly, wouldn't you say? For every 50, and you're normal. I wonder why Dr. Torres is with. And or you're eating too much sugar. Okay? And Michael stays on a very rigid diet. And he's nowhere near this because he does. But I'm a sugarholic too, and it's really mean to give a sugarholic, you know, this kind of disease. It's kind of a bad joke by God, really.
You have to watch carbs as well.
Oh, yes, I didn't see that. But that's a mixture of both, a function of both. You can have plain spaghetti and have it go that high too, so. Because pasta is full of basic carbohydrates. So. Yeah, he does.
I wouldn't say a special diet, but I watch, I stay low carbs, low salt, low sugar, high protein.
So from 150 to 200 is 50 to and 250. So for me, I need to take like 10 right now. And you know, it's really simple. You just beat your stomach. Get my readings on my phone.
Oh, I see.
See, that's a communications, that's a satellite, so to speak. That's your satellite, and this is your fuel right here. So before we end, after Dr. Torres, we'll check what my sugars are, see how it went.
Yeah. Normally, they would start you, if you're just early diabetic
Right.
on medication.
Correct.
metformin or some other.
Oh, I didn't say that. Oral medication.
Oral
There
medication
are
first.
several oral
But
medications.
we're gonna do a deep dive next time, right? on
Yes, that's it.
diabetes.
Okay, good.
So we'll do a deep dive, and so I know we had Dr. Caperna talk about like the latest studies. I'm gonna start from the bottom up, and then I think one of my things for this group, because you guys are gonna see me a lot, I signed up a lot to come and see you guys. Like have a whiteboard so we can have discussion and just really make sure like more of a workshop type of thing. Where I could get feedback and I'm hoping to answer all your questions. If not, you guys give me homework because I'm signed up to come back so we could answer anything that we don't get to, okay? So we'll start off, and diabetes is a huge topic in itself because it is tied to cardiovascular health. So heart health, diabetes has a very high risk of people with diabetes developing issues with their heart. So it's tied up a conversation that goes together as well as HIV. Okay, so I'm gonna start off. I jumped in there, and I hope to make this interactive, make this time go by quickly. And where you guys take like some useful pearls that you could apply to each and every one of our daily lives, what we could change, what we can improve upon. My name is Carla Torres. I've been an HIV provider for over 20 years. I'm a physician from Mexico, a nurse practitioner here. Been working in HIV, worked prior to joining. I currently work with FEB Healthcare. I'm a community medical liaison. My job is education. I've been given like a green light to work in community, get the topics the community wants to talk about and develop them. So like I said, this group is giving me that opportunity to do those deep dives and go back to the company and say, this is what the community wants to hear, wants information about. So you guys, it's a safe space, a safe environment for us to have these conversations. Dr. Caperna has been instrumental in my professional development. He was the first provider I met working in HIV, made me feel just in awe of how he works and his passion as a provider. And he's one of those people, mentors that made me fall in love in working in HIV. And then after that, it's the people and the resilience and the bravery, the people I surround myself with, and you guys are that, my people. And so it's really important for us to keep having these conversations. Cardiovascular disease is huge, a huge topic. Remember the shift in what we were talking about in the past. We would talk about just life-saving, kind of in the moment, not future-oriented. We have to now be future-oriented. Prevention is going to be really big and huge for us. And it requires this change completely in our mentality. We're going to be here. We need to do the best that we can as we age to change things that will impact our process of aging. We all understand when we talk about aging, it's happening to all of us. We can't stop it, but we could do things to make this process better for us. And what we do, the changes we implement today will have an impact. And I think that's important. We always want to be hopeful of what we can do. And that note is something that at the end of each of our conversations, I want everyone to take with you. So we'll start off with cardiovascular disease in general, what it is, and as we and I have some slides, just some visuals for us for our conversations. And I wanted to say, prior to joining FEB, I worked at Owen Clinic. I was there for over 5 years. And worked at San Isidro Health for 11 years. Worked a lot across the border as a provider. Again, doing volunteer work for over 20 years. And so the path that I've been on, I didn't start at the beginning of HIV, but I started in a really crucial time, which was 2002. At that time, what was happening, with the treatments that were available, and John talked about protein. There we go. There. Heart disease, okay, and then. So for each one of us, as someone who is living with, as unique persons, we all have different, what is called now cofactors, right? Each of those cofactors, because the decade will define what medications came available to you and what were those first medications that you were exposed to, right? And like we were talking about protease inhibitors, even farther than that, D drugs that were highly toxic. But as we discuss individual risk, and one of the big homeworks after this is to go and talk to your provider about your own cardiovascular risk and just have that personal conversation, because we talked about of those unique factors. So when you were diagnosed, what medications you were exposed to, how long it took you to get to undetectable, who knows why that might be a thing, why that would be an important thing or consideration, how long it took you to get to undetectable. Any thoughts?
How well the medicines work.
How well? So yes, it talks about you being at what time you were on effective medication that was able to suppress the viral load, and then Wanda,
I
anything
was
else?
gonna say, it could be because of the interchange with the different medications.
Okay,
To see what will work in your body.
yeah,
So that would be a heavy load.
yeah, your virus, that we know, high viral load, what does it mean? It means the HIV virus is circulating in the blood. What that does, imagine, for me, like my visual is blood boiling. There's a lot of virus. And then I'm gonna go here, and then I'm gonna go back here with you.
Well, that's what I was gonna say, more HIV has more time to actually affect you and do damage.
Okay, and there's a word I wanna hear.
Actually, genetics is a bigger part that people don't talk about. For
Resistant.
instance, I
Compliance.
went 20 years knowing that was positive without any treatment at all. And
And how your body evolved with the virus, the HIV virus.
it's,
So how would we know how your body evolved with the virus? Your T cells and your viral load, right?
Yeah.
Okay, so it's genetics does play a role.
but it, for instance, like I said, I went 20 years, and yet when I sat there and started my meds, I only did that because the doctor said that I could avoid having lymph nodes removed, but I had a lot of swollen.
So there was something going on for
And
sure.
so because I waited 20 years, I had an AIDS diagnosis at the same time.
Okay,
But I do know, I have another guy that I know that we both started about the same time. I actually went to zero fairly quickly, yet this person took
yeah.
a long
So
time.
it's different for
So that's why I
different
said-
amount of time for
Yes.
someone to get to
That's why I say
undetectable.
genetics also plays a important, apparently I was lucky.
So in general, for cardiovascular health, our genetics, our family history does play a role. I wanted to bring it down unless I could wind up.
For information.
Yes, you got it. It's a big word, and inflammation. As a general term can happen from different ways, from different pathways. And this thing and how it's related to that viral load is inflammation. Someone who was diagnosed, and remember at that time, because of the toxicities of the medications, people decided to not go on treatment, or because there were so many side effects associated to the medications, people would say, I'd rather just hold off. I don't want to take the medications because of fear of those side effects, right? From diarrhea, from nausea, from people would say, I don't know whether it's worth it to take a medication that makes me feel sick. And whether I have the virus or not, that dilemma, but that dilemma, leaving a viral load that's untreated produced inflammation. So how long we were exposed to that inflammation of having that virus not under control will impact the health of blood vessels in our heart. So we're talking about cardiovascular health, and we could look at that picture where it shows a blood vessel. That's what we're talking about when we talk about cardiovascular health, the health of our blood vessels. The health of our blood vessels is impacted by inflammation because it produces substances that produce damage to those blood vessels. And when the blood vessel is damaged, it increases the risk for things to get clogged up, right? To get damage. Think about the blood vessels, and you guys, if you've heard me talk about, I use these examples a lot, but think about a garden. Yeah,
On the brain, on the.
yes.
On the.
And we can have, the blood vessels can be impacted in the brain and the heart, but we're gonna focus again on the heart. So the health of the blood vessels, one of the things in particular, because I wanna highlight what it is different for someone living with HIV. What's the different, why are we having this conversation? This conversation it does need to take each person through their individual history to think about all those factors. What we said, when you were diagnosed, what medications you were exposed to, how long it took you to get to undetectable. Did you get the medication that you were able to tolerate and get to that undetectable viral load?
Estilo de vida. Estilo de vida.
So these
Health
also
is too
like
high.
markers, and if you have all these markers, then like.
Yeah,
That's
reminder.
what we're talking about, how we
Just tells
respond to
me.
that. It's-
Yes.
it's-
What can we do about it, right? So this is kind of the baseline and the history of, right? For people living with HIV, that's the difference between all the basic cardiovascular risks. I want to hear around the room, what are the cardiovascular risks that we already know? I've highlighted some of the things individual for HIV, but in general, what do we already know puts us at risk for having issues with our heart? I heard genetics already. What else?
High blood pressure.
High blood pressure, and I want to get into high blood pressure a lot because that's a big common denominator.
Cholesterol.
Cholesterol, and Dr. Caperna talked about it.
Yo lo voy a decir en español. No lo traducir. Más o menos estoy entendiendo.
Yeah, she's trying. She's
Quizás todas las causas, ¿no? Que llevan a eso. Pero en
She's
en
already
la-
all
en
the
la- en las
causes
personas viviendo con VIH,
that lead to issues with your heart.
con respecto a la población general,
In difference with the
tienen
general
el riesgo
population.
de las enfermedades propias del envejecimiento.
There's a risk of conditions related to
Lo
AIDS.
que sucede en el paciente que vive con el virus es que el virus de por sí solo puede producir estas enfermedades. Aparte de algunos medicamentos, sin embargo, tenemos medicamentos que protegen las enfermedades cardíacas. Y además que todos estos tratamientos han aumentado la expectativa de vida y entonces se suma el envejecimiento con la infección y por eso es que hay esos riesgos mayores.
So, and kind of in general, just to summarize, as and we've talked about people living with HIV are not now aging, right? This is a chronic condition, chronic, well-managed condition, and I call it in my head a cofactor. HIV is just a cofactor because most people now on treatment are doing well. The HIV is under control. The T cells are good. But the baseline, the history that we talked about is going to be important. So as we all age, and that's kind of, to summarize it, age is a risk for cardiovascular health.
Diet would be one, right?
Diet is another one. Being age, and for me now, 40 sounds really young because I'm 53, right? But being 40 and older already puts you at risk for cardiovascular issues. Yes, and you were gonna say, I'm sorry. No? Okay, good. So it was you. I'm so sorry.
Lack of exercise.
Not exercising, but you were gonna say as well?
Yeah, you've also got a high salt diet.
Sodium, yeah, your diet, so diet definitely, exercising and John? Stress, definitely. So you guys, because like we're gonna be really close knit working, help me remember all of your names. So tell me your name so I can start registering, okay? I wanna make sure like that we have that relationship, right? So you guys feel that this is a space where we could talk really, really well.
Genetics, playing Bell, genetically good life. Have a family familiar history.
Family history,
Mhm.
yes. And your name?
Al.
Al?
Yeah.
Okay. So family history for sure. We already said family history, hypertension. John talked about his diabetes. We talked about diabetes. What else? Exercise, the diet, the cholesterol. I think we got most everything that are considered risk factors. Yes.
Triglicéridos.
Colesterol and triglicéridos, cholesterol and triglycerides.
Smoking.
Smoking, that's a
Smoking.
huge one. You're almost
How did
missing
we
that
forget?
one. And that's huge. It'll come back.
Smoking / drugs.
Drugs, yes. And here's an interesting thing for you guys, which is newer. Marijuana, smoking marijuana. People think tobacco only, but we actually now have data that smoking marijuana affects cardiovascular risk. So these are newer conversations that were not taking place.
But what I was gonna say, I remember when I was first diagnosed with heart disease, I started to ask myself, what was I doing wrong? And I'm blaming myself for like my diet and all this stuff, and what you're speaking about is it's like not a result of the things that I've done wrong, it's the conditions that I've been subject to for having done these medicines for so long.
Exactly.
And then those things are important to do, but it's not like I just feel like it's important for us to not blame ourselves for
Yeah, that's
having
really
these
important.
conditions.
That's
you know.
really important. And that's one of the things, remember, we want to end things positive and in a positive way. No blaming, like we have whatever condition we have, and then just how do we move forward? And
I know the people said it, not movement.
yeah, activity, physical activity and stuff.
People just sitting around watching TV all day long.
Yes,
You know,
yes,
so
yes,
it's not even be like, oh, okay, I'm just gonna plug out.
yes.
That's what I think about.
So I love that you guys are all involved in this conversation. So we get it. We're talking about cardiovascular, and we're actually talking about the health of our blood vessels. That's how it translates. One of the biggest complications that we have or that we fear in having is a heart attack. Okay. And my kind of due diligence with this group is that we are all talking to our providers about our own risk. And we're going to talk about what action items we need to take in regards to reducing or preventing any or cardiovascular risk.
I think I'm more afraid of having a stroke.
It's scarier.
I'm more afraid of being disabled than I am of dying.
Oh, yeah.
So,
That's actually really
yeah, so are they
good point.
the same, caused by the same thing?
So it's it's still the health of the blood vessels, but up in the brain. And we could have, I think that requires us to have a deep dive conversation on stroke, right?
Right.
And I'll kind of put it in my list of conversations that we need to follow up.
Definitely.
So we're gonna put in the parking lot about talking, that's what we're gonna do. If we haven't addressed it, and then Wanda and you guys, John, help me remember to go back and note that this is an important topic. And then we're recording, so
Yeah.
we'll have evidence to the fact. So I quickly wanted to talk about what are the signs and symptoms of a heart attack?
Weakness in your arms or all your extremities, you know, you
Just feeling weak?
yeah.
Is it different for men's versus?
Yes, it's different for men versus women,
Getting out
cisgender
of
women.
breath really quick, if you're walking or whatever, and you can't keep your breath.
Your breath, right. And one of the biggest things, especially for cisgender men that we talk about like by the book, is coming in with chest pain.
Yes.
Okay.
Like an elephant standing on.
Exactly. And everybody close your eyes, think about how an elephant sitting on your chest would feel. So that's the pressure. So pressure and it goes to your left arm, usually, that's for cisgender men, usually the presentation. And difficulty breathing, nausea, feeling your heart beat faster and stuff. So the other thing that is really important when we talk about cisgender women and how it could present differently, mostly it's referred as back pain. It could be jaw pain. It could be the nausea, the wanting to vomit, cold sweats. It's different. So if I have any suspicion someone's having a heart attack, it's an emergency.
Yeah.
It's a 911 call. Time is of essence, right? I want to get that person to care within 30 minutes, ideally, to get the most common cause of a heart attack is, or the cause of a heart attack is having the obstruction by a clot that's stopping the circulation of blood to the heart. So if the function of the blood to the heart is to take oxygen, right? And so if blood is not flowing freely to the heart muscle, the heart muscle dies. And so we have effective medication that could treat a clot and dissolve the clot. That's why time is of an essence. If I'm in doubt, it doesn't matter. I want to get that person checked out and to determine if it's really a heart attack. There are things that could look like a heart attack, and I'll mention those as well.
I just want to say, you may not feel the pain, because I had a heart attack, and it was just out of breath. That was it. I mean, but I was really out of breath. I mean, I had to sit down, and then my breath came back to me, and I started walking, and it was like, well, I'm out of breath again.
The things that we want to do is create more awareness of our body, create more awareness of our own health risk. So we could try to be pointed in the direction, but being out of breath, not good. An emergency, it's an emergency, right? Yeah, you guys.
Yeah, I'm not big at, most of what's kind of brand is very big. So what you're taping, in the movie, you get drop the tape so we can let him hear it. But right now, he just filed and he's not able to come here.
Oh, yeah, it's being recorded, so it'll.
I just want to record it so he can hear this.
Yeah, so there'll be access to our conversation.
Talk to me, Al.
Okay, awesome. And so so we talked about the heart attack emergency. That's my key message for that. Understanding it could be a little bit different, and then my own awareness with my conversation with my provider to understand my risk, right? And so next, and I'm so sorry. Next to whom?
Your secretary.
Secretary, my assistant. I'm sorry. So the other big topic is high blood pressure.
Yeah.
So high blood pressure can be the start of heart disease, or it can come with heart disease. So by definition, what is high blood pressure? Who knows? And hypertension. What is hypertension? Hypertension is high blood pressure. And so why would that matter?
Causes the heart to work harder.
Yeah.
Makes the heart work harder, Wanda?
That's really the stroke. I mean,
Yeah. Yes, and how can you reason?
Yeah, because it's, like I'm on like 4 blood pressure.
So it's
Yeah,
It's-
it's a challenge.
it's a challenge to control.
Reg, is syncope a condition of high blood pressure?
Sometimes.
I don't,
But
I don't know, I know I have it, but I just know that sometimes I have to move slowly because if I change states too fast, I'll sometimes pass out.
okay, so
But
potentially not the most
But I haven't
common,
been told that I were risking anything, the medicine that said
and you
that,
don't have high blood pressure.
not as a rule.
Okay. So it'd be, and you guys, the other thing is that we want to empower everyone to have those conversations, and I want, for example, in this case, give me your name.
Reg, that's
Reg.
Reg.
Okay, Rich. So to your provider, to clear that up, why do I have the diagnosis syncope, and I need an explanation to understand, right? So I would want you to have that conversation, because only your provider could really answer that specifically and tell you where that's coming from, okay? So follow up with that, please, Rich, okay? And then for hypertension, one of the big things for high blood pressure, every time you go to the doctor, your blood pressure is checked. Now it's a machine. I used to have to like, I can't hear. And blow up your arm and so what, does everybody understand what we're doing there with that test, how it works? Who wants to explain it to me?
It measures the outflow of the pressure of the blood going to the arteries and the veins, or out of the heart and back to the heart.
Exactly, and how it does it, we put pressure on your arm. You guys know that sound, and that cuff, that blood pressure cuff is collapsing the circulation of blood to your arm. And then we let the pressure go down by opening a valve to slowly listen when the heart starts beating, when not with the heart starts beating, when the blood starts passing, to know what is the pressure that blood is flowing through. Okay, so those are the readings. So how many numbers do we get when we get a reading? Two. What are the names of those numbers?
Diastolic and systolic.
Okay, which one's the high one?
Systolic.
And the lower one is diastolic. So two numbers, two readings. Blood pressure guidelines have changed dramatically through the course of years. And there are different guidelines for different, like for the European Association, the American Heart Association, and the there was another one, some other. So
Dr.
there's
Torres Association.
my guideline, no, I didn't have to stick to the guidelines, but in general, the conversation has evolved through the years, and we were a lot looser with the numbers in the past. I always talk about, like, I'm that old when we used to say 100 plus your age was the systolic reading. That's totally a no-no.
Wow,
Like,
that would-
imagine, so if I stopped reading, I would have gone with that. So blood pressure, now the guidelines are really strict. And so the American Association of Cardiology, they got stricter than the European guidelines, where who has an idea about what's the target? What are the numbers?
Low blood pressure starts at 90/60, and high blood pressure starts at 120/80.
What was that?
120/80, that's the top range of normal.
Yes, exactly. And so that's very different from what we knew in the past, right?
And is there normal for different normals for different?
Yes,
ages?
and that requires a specific conversation. If I'm diagnosed with high blood pressure and I'm on treatment, I'm going to discuss my treatment goals with my provider. And I want to tell you, like, my mom is 84, she's going to be 85. Her blood pressure goals have changed dramatically. She also struggles with or has a diagnosis of Alzheimer's, but her blood pressure medication, because if I just stick to the guidelines, her blood pressure was considered to be elevated, but it actually impacted her brain. And so she doesn't need to have that lower range that maybe someone who's younger needs to have. Okay, so that's why the goals are individual for each one of us, right? So even though I'm talking pre-diagnosis of high blood pressure, less than 120, less. So much stricter. European guidelines, remember that old number, 140, old number now, 140/90, which was when with the diagnosis, that was stage 1 high blood pressure. Now for for the Association of Cardiologists, it's stage 2. So it went up, stricter control. So those numbers are evolving. But again, what's the homework? Homework is know what my blood pressure is. Know what my target is. And if I'm on treatment, we're going to talk about, and hopefully probably don't have much more longer time. Like, how much more time do I have? 10 minutes. Okay, so I'm going to wrap it up because I still could talk about this a lot more. But what we're going to do when John and I present, I think in April,
Yeah.
we'll touch upon some other topics because again, they're related to diabetes. Okay, so we'll follow up. as we wrap up, we talk, one other thing that's just brand new about the diagnosis of of hypertension, of high blood pressure, talking about two readings, checking your blood pressure sitting down and checking your blood pressure standing up, okay? And sometimes when we're in clinic, usually get it checked only one way. Is that, am I wrong?
No.
Correct.
Right?
One
So the other big thing is if I'm getting or have the diagnosis or pre-diagnosis of high blood pressure, getting a monitor for home, and a lot of insurances will cover a blood pressure monitor is a great idea. Because you guys, I'm a provider and I would get so nervous when I go to see my doctor. I get embarrassed and my blood pressure gets high. And so checking at home is a better baseline for me than at clinic. So it's called white coat hypertension and anyone can have it. Whether it's for being shy or just running into the doctor and so that's why checking at home is such a good tool.
I don't know what the guidelines are for getting it, but I have one. It's a blood pressure machine with Bluetooth that's connected to my cardiac
Oh,
doctor.
wow.
They get the readings,
Yeah, so
And, you know,
that's
I-
awesome.
I'd also like to say I take my blood pressure every morning and I manually record it on my phone. There's an app to record it and keep track of it for 30 days, 90 days, 180 days.
So different tools, different resources, but that's us being proactive and staying on top of our health, okay?
Yes, I was just diagnosed, I got high blood pressure,
Okay,
and then I just went to the doctor, and surprised the hell out of me that I got atrial fib. And so they're putting me on another medication.
Yeah. so that's a heart rhythm condition.
yeah.
Yes, and it can be controlled. There's treatment and there's other steps that can be taken to make sure that's under control. The good thing always, it's been diagnosed. So having it diagnosed and treated is like, I'm being taken care of, right? Not knowing the risk of having untreated AFib is hard for stroke, having a stroke and other conditions. So it'll be okay. So it's important. And then getting blood pressure under control, as you see, it's not easy. It requires a lot of stuff. And we had a
Oh, they always, when they take your blood pressure, they want your arm up and your legs uncrossed.
yes.
Or yeah.
And then ideally, when we have an appointment, we want to come in with enough time where I could chill a little bit.
Chill out.
And I'll be, you ran in because that impacts that reading, okay? And the other thing, if I already know what my baseline is at home, I have a better measure, okay? So I want to kind of wrap up with some like key takeaways, although there's so much more that we could get into, but so things that we cannot change, the passing of time and age, right? We're all aging. That's nothing we could do. We could age gracefully, but other than that, there's nothing more that we could do. Our family history, our genetics. If you have good ones, yay. If we don't have great ones, but we can't do anything more about it, right? So that's not something that we could change. And there's some specifics that are associated to the gender that we were assigned at birth. And that can also, so there's like some discussion, it's not talked about as much, but in general, we talked about the big ones, the passing of time and our genetics are things that we cannot change. What we can change is all of the other stuff that we talked about. And I really wanted to touch upon, for example, sodium. What's the recommended amount of sodium?
1800 to
Yeah.
2200.
24, 18 to 24, which is how much? Like I hear that number and like,
Like a teaspoon.
one time. So here's one cup of noodle. A cup of noodle have more than like, or that soup in a bottle and what's it called?
Ramen cup of noodle.
Things. Those things have a ton. They have the salt for the whole day.
Right.
Think about outside of the salt shaker. It's not the only place where sodium is, right? It's not this. What are other sources of sodium? There can be.
40.
How much can you read it for me?
40.
40. Okay, a little bit.
olives and kind you get at Costco, they're supplemental,
Mm.
200 each.
Really?
Yes.
Wanda,
So look at the canned goods or canned soups that they purchase, because they also have a high doses.
and then the positive, or one of the good things, there's reduced sodium version. So another high source of sodium is like soy sauce, but there's reduced sodium soy sauce. There's canned soups that can have or condensed soups that can have a lot of sodium, but there's also reduced sodium canned soups. So it's some of that. Sources, other is how we prepare our food, and John.
If you buy any TV dinners type thing,
Oh,
already
can be
prepared,
very high.
it can be very high.
Yes.
Take a look at the sodium in the
Yes.
stores.
And here's the thing, and I know some of us face difficult challenges, whether it's with access to food.
Yeah.
But there's ways where we could do things a little bit better in regards to there subtle things, and nothing is, there might be something else that we could bring into the mix. Maybe if I had a TV dinner, I know I'll try to avoid sodium, other sources of sodium that day, and things like that, right?
Yeah, I heard a thing the other day about, one of the reasons that restaurant food tastes so much better than home cooking is because they don't care how much sodium, or how much salt is in it.
Yeah.
And so you might talk to wherever, if you eat at someplace on a regular basis, you might talk to them about, is there a lot of sodium in this or that, you know?
Uh-huh.
Yeah.
I think that's really a great advice. And the other thing, when we cook, think about, again, it's not only cooking with the salt shaker, but everything, like I know as Mexican, as a Latina, my mom would always, actually still, I have at home, chicken bouillon or in powder, which is called Nor Suiza, that's the brand, or consomé de pollo. It's my mom, I don't add sodium to the food, but that's the sodium, so it's a different source, right? And she thought she wasn't adding any sodium to our food, but like there's other options like Mrs. Dash, but and many of those flavoring things, sauces are high in sodium. So consider that, like, even though you're not specifically adding sodium.
Yeah, almost everything we eat has some level of sodium.
Yes,
And we need sodium in
Yes.
order for electrical.
that's a good balance. Let's balance it out. Yeah.
So no sodium is a bad idea.
Bad
Too
idea.
much sodium is a bad idea.
Yeah.
The worst thing you're gonna find in the stores for sodium is anything that's marked low fat.
Because they'll flavor it up with sodium.
Exactly.
Yes, and that conversation about low fat, I always get a little like that because my parents grew up at that time that was the advice that they got. Low fat was a solution to everything, but they were getting so much sodium and so much sugar. And my dad died of a heart attack at 57, and now I'm 53. So that I'm like, oh, that's young, right? It's like when you get there, like at that time. So I think that's a really valid point. And I always want to make sure that I'm not giving you like a task that seems impossible, right? It's something that, what can I do to make things a little bit better? That's kind of my goal. It's like, I always say it doesn't have to be either black or white or perfect, or like a little improvement goes a long way. Changing one thing or having more knowledge about one thing will impact your health. And I think I can't get into anything more because we're at time. Any questions that we want to address?
Right.
I think like smoked foods and cured foods, aren't they high in salt?
Yes.
Lunch
uh-huh.
meats.
Lunch meats, yeah.
Lunch meats.
Right.
That's huge.
I'm a John too.
Oh,
So, what about sea salt or pink Himalayan sea salt?
oh, and I was having that conversation with Dr. Caperna. So that they marketed like pink sea salt or Himalayan salt as the best of like it had some. It's like honestly, it's salt. And so don't think because you have Himalayan pink salt you could go crazy on it. It's still a source, and it's actually because it's not finely grounded, it can have a higher concentration of sodium. And so think about that, about being careful. And remember, it's not that I'm saying no sodium, but just want you to be aware of that, okay?
I just like to say the reason to avoid salt is because salt attracts water, and water makes the heart, if that increases your blood pressure and it makes your heart pump harder, and it can even bleed into your lungs. and your ankles and your other, you know,
Exactly.
I've been in that-
Loads the heart.
Right.
The heart can't take it, that,
Right.
so it pulls in volume that the heart is not unable to handle.
Right.
And that's what we call
Hey, guys.
cardiac insufficiency.
Hello, Doctor, we can hear you more than we can hear Dr. Torres, so please don't talk.
So cardiac insufficiency is when the heart is unable to handle the load that's coming to it, and it overflows. And have you ever had water in lungs? Like,
Yes.
that person has water in their lungs.
Had to be
It's because
diuresed.
yes, and the feet, the swelling of the feet, and one of the questions you'll get asked, like, are your feet swelling? Because we want to know how your heart is handling that high blood pressure. If it's not handling it well, there'll be signs, and having shortness of breath can be related to having some fluid collection in your lungs, and you could also see it, your feet getting swollen. So, yes.
Is that related to gout? Because
No, it's different.
Oh,
Yeah,
okay.
it's a little bit different. Yeah. So I want to thank everyone. It was fun, right? I hope you guys took something. Thank you so much.
Thank you, Dr. Torres, really appreciate it, it was wonderful to see you.
John, thank you.
Thank you. He's coming back. Hold on. Okay, just a few minutes, we're just gonna pass out the schedule.
Yes, so, not bad.
What are you passing?
That's all I that's there.
Oh,
Okay. Sí, 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 yo te hablo.
I'm glad it's resolved that.
it was right here.
My